Hi dear students, today we are going to talk about seronegative spondylitis. These are the special group of diseases which share some key clinical and pathogenetical features. The family of spondyloarthritis involves ankylosing spondylitis or so-called Bacter's disease, reactive arthritis, psoriatic arthritis, spondylitis associated with inflammatory bowel diseases like Crohn's disease, non-specific ulcerative colitis, and non-differentiated spondylitis, which means that we don't have specific criteria, like we don't identify specific criteria to confirm a diagnosis of specific spondylitis, so we say this is non-differentiated spondyloarthritis. The diseases of this group are negative for rheumatoid factor and anti-nuclear antibodies. That's why we say these are seronegative spondylitis. We don't identify any rheumatoid nodules. It's common for these diseases to have asymmetric involvement of peripheral joints. Uni or bilateral sacroiliitis is common. We can also have the inflammation of aorta, and we can have also the association with HLA-B27 and positive family history of these diseases. What is enthesitis? Enthesitis is an inflammation of the junction of the ligaments, tendons to the bone. And this can be, for example, in the area of greater trochanter, can be on the region of the knees, for example, can be on the plantar region, or can be like in bursitis. Also, ankylosing spondylitis, or so-called Bacter's disease, is a chronic inflammatory disorder of spine. Here we have spondylitis. Then iliosacral joints, we have sacroiliitis, peripheral joint involvement, and we can have also enthesitis. We can have also involvement of eyes like uveitis. We can have aorta inflammation and other systemic manifestations, and we are going to talk about these systemic manifestations later. Mostly men of certain age, which is from 20 to 40-45, are predisposed to it. It's not very likely to have the onset of disease after the age of 45-50. Although here it's important to mention that the diagnosis of mild, or it can be like subclinical or even asymptomatic disease, may be made at a later age. Also, we should mention that female patients tend to have milder forms of the disease. So, etiology of ankylosing spondylitis is generally unknown, but of course there is genetic predisposition, which is the positive HLA-B27. It's believed that in this disease model, we have upregulation of HLA-B27 under some circumstances. Maybe it can be like specific gut bacteria or some biomechanical stress. And in pathogenesis of disease, some cytokines like interleukin-23 hyperproduction will cause the activation of T cells, which will produce interleukin-22, 17, TNF-alpha. All of these cascade will cause bone loss, which is bone loss, inflammation, and osteoproliferation. Generally, we said that the key cytokine here in pathogenesis is TNF-alpha. That's why one of the basic biological treatment here is TNF-alpha inhibitors, when the other treatments are not very useful. So the involvement of spine here in ankylosing spondylitis, we have the involvement of spine can involve chondroid connections, entheses, bones, and joints. So in the place of inflammation, chondroid metaplasia, and ossification and ankylosis can occur. In the course of the disease, the patients will have atrophy of spine muscles, And two types of spine deformities can occur. I want you to show this. So, when we have, first of all, when we have cervical lordosis and thoracic kyphosis, as we see in this picture, this is the beggar's position. And the second deformity, this is total rigidity of spine, which is a disappearance of all physiological curvatures. On physical examination, we identified the limitation of motion in spine. So, to assess the limitation of motion in lumbar spine, we perform Schober test. As shown in picture, we make a dot on the level of spina iliaca posterior superior, as it is shown here, and the second one 10 centimeters above. We ask the patient to bend forward and measure the distance between two dots. In normal spine, we should have enlargement of at least 4 to 5 centimeters. If less, we talk about limitation of motion. So, very important clinical manifestation is sacroiliitis, which is typically bilateral in ankylosing spondylitis. So, we are going to talk about peripheral enthesitis and joint involvement, peripheral arthritis, which is the key manifestation of the diseases of family of seronegative spondyloarthritis. Mostly this is in lower extremities in ankylosing spondylitis, and mostly this is asymmetric oligoarthritis. Although it's important to mention that in ankylosing spondylitis, patients can have bilateral hip joint involvement, which can cause severe damage and even joint replacement may be needed. So what about enthesitis? We can have plantar fasciitis. It's very typical for ankylosing spondylitis. It's very painful, especially in the morning. So we can have also enthesitis in the region of greater trochanter, knee region, epicondyle region, which not only the involvement of the lower extremities is possible, like in peripheral arthritis, we can have also the glenohumeral, acromioclavicular, sternoclavicular joint involvement, which are typical, not very common, but are typical for the costovertebral joints or costosternal junctions, which are very typical for ankylosing spondylitis. What about dactylitis? Dactylitis is more common for psoriatic arthritis and reactive arthritis. So sausage-like digit is not very common in ankylosing spondylitis. Of course, we can have small joint involvement here, but mostly we have big joint involvement. We can have also next manifestation as extraarticular manifestations. First of all, this is eye involvement. This is uveitis. Mostly this is anterior unilateral recurrent uveitis, but of course bilateral is also possible. Next is the inflammation of aorta. We can have also pulmonary involvement. This is the apical pneumofibrosis, and even cavernous or emphysema can occur. Here it's important to mention that in management we have to tell these patients if they are smoking to quit smoking, because smoking can also exacerbate this pulmonary disease in ankylosing spondylitis. Next is renal involvement. IgA glomerulonephritis can be here, and the main clinical manifestation can be hematuria. But we have to say that mostly this glomerulonephritis is a benign case, so it's not very severe. In 1% of cases in ankylosing spondylitis, patients can have amyloidosis. So, which type of amyloidosis? Of course, this is type AA amyloidosis, as the amyloidosis of the chronic inflammatory condition. Next, we are going to talk about metabolic bone disease. Although we mentioned that the key feature of ankylosing spondylitis is the new bone formation in the places of chondroid metaplasia, long-term inflammation will cause osteoporosis with increased risk of fractures, especially in rigid form of deformity. Why? Because these patients are losing the physiological curvatures, which are, as we know, the protection of the spine. That's why when patients with severe spondylitis who present with acute exacerbation of back or neck pain should be re-evaluated for possible fractures. Mostly by CT, because X-ray is not very can be not very sensitive here. A very good picture of X-ray, a picture of bilateral sacroiliitis. Here we see bilateral sacroiliitis, and this is approximately grade 3. So for X-ray evaluation of sacroiliitis, we use Kellgren staging 0 to 4. In the last stage of sacroiliitis, we have total ankylosis. Here we don't have any total ankylosis. That's why I say this is mostly for stage 3. So what we see here, this is a typical sacroiliitis sign. This is the subchondral osteosclerosis here. Subchondral osteosclerosis. We said that new bone formation, osteosclerosis, and bony ossification and proliferation is very typical for ankylosing spondylitis. Joint space involvement here we have, and the joint surfaces. What we see here, we have even big erosions, very typical for the severe form of bilateral sacroiliitis. What we have here, a late stage of ankylosing spondylitis, the bamboo spine in ankylosing spondylitis. Here we see bridge syndesmophytes, which are symmetrical. You see symmetrical syndesmophytes, where two vertebrae are connected by this bridge syndesmophyte. And here what we see total ossification of the ligaments of the spine here. So, and on this X-ray, what we see a heel spur here. This is a type of new bone formation in ankylosing spondylitis. And here, as we know, of course it's not seen on X-ray, we see plantar, we have this plantar fascia which is connected here by heel here, and when we have inflammation here we have chondroid metaplasia, then ossification and new bone formation, very typical for ankylosing spondylitis. On this X-ray, we see symphysitis here. This is also very typical for ankylosing spondylitis. And of course, we're going to talk about treatment of ankylosing spondylitis. Here, it's very important to say that we should have special physical activity. For example, swimming. Also, is considered to be a very good option for ankylosing spondylitis patients. We have to tell this patient to have normal posture. It's also very important, and this special physical activity should be on regular basis. Next, nonsteroids. This is considered very good option of treatment, but this should be a long-term treatment. Local steroids, glucocorticosteroids, can be used like intraarticular or periarticular treatment. It's believed that systemic glucocorticosteroids are not indicated here, although if we have, for example, systemic manifestations, high doses of short-term, but of short-term usage of glucocorticosteroids can be indicated here. Next is sulfasalazine, which is the disease-modifying treatment, but for peripheral arthritis. It is believed that sulfasalazine is not indicated for axial, like for sacroiliitis treatment. And if we have very high activity of the disease, we have some indexes, for example, BASDAI index. and laboratory tests are very high. For example, ESR is very high, and we don't have any good response on this treatment. Biological drugs, which is, for example, TNF-alpha inhibitors, should be considered here. So thank you very much for attention. Next topic is reactive arthritis, which is non-purulent inflammatory disease of joints which occur after intestinal or urogenital infection. Mostly young men from the age of 20 to 35 are predisposed, but disease can develop at any age. Generally, reactive arthritis is associated with intestinal infections like Yersinia, enterocolitica, Salmonella, Shigella flexneri, and from urogenital mainly Chlamydia trachomatis, Uroplasma, Mycoplasma. Here, as in other diseases from the seronegative spondylitis family, we have connection with HLA-B27. So, the period between the urogenital or intestinal infection and the onset of arthritis is between 3 days to up to 2 months. So, which joints can be involved here? Predominantly, these are the joints of lower extremities as asymmetric arthritis. Unilateral sacroiliitis is also common. And of course, enthesitis. We know what is enthesitis from the ankylosing spondylitis pictures. So this is especially on the plantar region, like plantar fasciitis, which can cause also spur formation, and ankylosing also can be. Enthesitis at the region of greater trochanter can occur here. So here we should talk, of course, a little about dactylitis, which can be not only reactive arthritis but also in psoriatic arthritis. This is so-called sausage-like finger, which is the inflammation of periarticular structures of the fingers. So we have, of course, some other clinical features like skin and mucous membrane involvement. Mostly this is here we see conjunctivitis, can be also uveitis and balanitis. And also can be erosions on the mucous membrane of the mouth, but these are mostly painless. On skin involvement, we can have keratoderma planoregica, we see here. These are mostly papillous squamous rash, and on the plantar and plantar regions can be also on palms, and this can resemble can even resemble psoriatic arthritis. Involvement of the nails here we see can be onycholysis, and these are also common. From systemic involvement, we can have fever, aorta inflammation, renal involvement as glomerulonephritis, amyloidosis, which is mostly AA type of amyloidosis. Myositis can occur. So, reactive arthritis can be acute, this is the first 6 months, and chronic, more than 12 months. How to confirm the diagnosis? We don't have specific criteria for diagnosis, so we should have normal anamnesis, we should have a physical examination, laboratory test like HLA-B27 is very useful here, elevation of ESR, CRP, we can have also leukocytosis. We can try to identify the underlying infections like in urogenital. Mostly we perform PCR. So when we confirm the diagnosis, we start with the treatment. Mostly antibiotics are indicated only if we have urogenital infections, because there is no reason to have antibiotical treatment if we have only the intestinal involvement. So next is nonsteroids to treat like joint involvement and enthesitis. Local steroids if nonsteroids are not useful. Local, which is the intraarticular or periarticular, like in enthesitis. Systemic steroids are indicated in low doses when we have systemic manifestations. If all these things they do not work, we start the basic treatment, which is the disease-modifying treatment, sulfasalazine, methotrexate. But these are only for peripheral arthritis because there is no indication because these are not useful for the axial involvement. And if we don't have any like if this treatment is not useful, we use biological drugs. Mostly this is anti-TNF-alpha treatments. Thank you for attention. So here we have 2 cases regarding some seronegative spondyloarthritis. So let's start with the first case. A male patient, age 22. He was admitted to the hospital and he was complaining from general weakness and diffuse myalgia and hematuria. Of course, on physical examination, there was swollen right knee and left ankle with limitation of motion, and also he had a swollen finger on right hand, and there was a diffuse swollen finger, which means this can be dactylitis. We have also a picture, so we'll discuss about it later. All these complaints, the patient says that all these complaints are for 2 weeks, and also he had low-grade fever and blood pressure was normal, and he had also a treatment for diarrhea, and there was 1 month ago. This is very important for the diagnosis. And what's important also, he was totally healthy before this diarrhea episode. Now he doesn't have any intestinal problems. So of course he had examinations, and he had general blood test, and he had mild leukocytosis, mild thrombocytosis. Erythrocyte sedimentation rate was 44, CRP 48, and also he had HLA-B27 examination, which was negative here. So rheumatoid factor, anti-nuclear antibodies, NCA are all negative. On urine analysis, we had hematuria and mild proteinuria. Of course, he had abdominal ultrasonography and X-ray of the chest. There was nothing significant was revealed there. And as he had articular problems, so there was also ultrasonography of the joints. And what was revealed there was enlargement of synovial membrane with increased vascularization, and also the intraarticular liquid, the volume of intraarticular liquid was increased. So what does this mean? This means that we have here the ultrasound signs of acute synovitis. So because of this synovial membrane enlargement with vascularization, so this is all the signs of synovitis. So here is the hand of this patient. What we see here is the diffuse swollen finger. This is because of the inflammation of periarticular tissues. This is the typical dactylitis, which we said that it's not very typical for ankylosing spondylitis, but it's one of the key clinical features for psoriatic arthritis, for example, or reactive arthritis. So this is called dactylitis. So what is the most probable diagnosis here? First option is ankylosing spondylitis. Why this is not a good option here? Of course, this can be ankylosing spondylitis because we had all these tests and anti-nuclear antibodies. Rheumatoid factor are negative, so we have seronegative arthritis, and we have predominantly involvement of the lower extremities with oligoasymmetric arthritis, as in can be also in ankylosing spondylitis. But we said the question is most probable diagnosis. As the age and this, we had a previous diarrhea, so we have connection. Especially we had this arthritis onset after this diarrhea. There's like 1 month after this diarrhea episode, so we don't have typical ankylosing spondylitis connection with this diarrhea. So this is not most probable diagnosis here. Third option, non-differentiated arthritis. Why not? because in order to say that we have non-differentiated, we should not be able to identify specific arthritis here. And so this is more probable. A probable diagnosis will be post-enterocolitic reactive arthritis. Why? Because we had these intestinal problems 1 month before the arthritis onset, and age, and being male, and having asymmetric oligoarthritis and a connection, especially connection with previous diarrhea, we can have this most probable diagnosis of reactive arthritis. And why not rheumatoid arthritis? Because we have specific criteria for rheumatoid arthritis. Of course, rheumatoid arthritis can also start with oligoarthritis, but the typical, which means this is not probable, typical manifestation will be polyarthritis and not oligoarthritis, for example. And also this connection, again, the connection with the previous diarrhea. So most probable diagnosis here will be reactive arthritis. So here, what is the first line treatment options here? First option here is antibiotics, which is not right. This is not a good option here because we have indication for antibiotics when we have the connection with urogenital infection. If we have intestinal infection, it's not effective. It's not proven to be effective here. So antibiotics is not a good option here. Second, nonsteroids. Of course, this is a very good treatment option for reactive arthritis. Third will be intraarticular injection of steroids. Also, this is also considered to be very effective, especially if we have only 2 joint involvement. So intraarticular injections of glucocorticosteroids will be very effective. And the fourth, sulfasalazine. Here in this case, sulfasalazine is not indicated. Why? Because the duration of this disease is only 2 weeks. So if you have recurrent arthritis, or the duration of arthritis will be more than 12 months, then sulfasalazine will be a good option here. So as you remember, the duration of reactive arthritis. So the forms of reactive arthritis can be acute reactive arthritis. The duration will be 6 months, and chronic, even more than 12 months. So in this case, when we have chronic arthritis, then sulfasalazine is a very good option for peripheral arthritis. So here, as we have only 2-week problem, so there is no need to start with sulfasalazine. So here we have the second case. Male patient, age 45. He was admitted to the hospital, and he was complaining of pain in his buttock and back region. Interestingly, he mentions that this pain becomes better after physical activity, and he has this back pain at night, and he says that duration of these complaints are at least 2 years. He says that he had an episode of swollen knee, and that was 2 months ago. He says that he didn't go to the physician for this swollen knee. On physical examination now, he has both knees are swollen and with limitation of motion. He had also limitation of motion in lumbar spine, and shoulder test is 3 centimeters. So you remember what is shoulder test? This is how we assess the mobility of the lumbar spine. And there was no limitation of respiratory excursion. So the laboratory tests revealed ESR 60, erythrocyte sedimentation rate 60, CRP very high, 156. Rheumatoid factor, anti-nuclear antibodies are both negative. what is important here, HLA-B27 is positive. And of course, some other examinations, for example, X-ray, revealed the second grade of bilateral sacroiliitis and some syndesmophyte. So we have also here here we see the enlargement of the joint space of iliosacral joint, some subchondral sclerosis, but we don't see any erosions on the joint surfaces. So this is approximately a second grade on Kellgren classification of bilateral of sacroiliitis, but here we have bilateral sacroiliitis. And on this picture we have a very severe form of syndesmophytes and even the total ossification, like you see here, and this is the typical syndesmophyte. So what will be your most probable diagnosis here in this presentation? First option, ankylosing spondylitis. Second, reactive arthritis. Third, rheumatoid arthritis. And last one, Behçet disease. Let's start with the last one. Why not Behçet disease? Of course, having oligoarticular manifestation, especially of the lower extremities, like we had in this presentation, having sacroiliitis, for example, also are typical for Behçet disease, but not bilateral sacroiliitis. Mostly for Behçet disease we see unilateral sacroiliitis, and not only the main manifestation of Behçet disease is not articular. We should have ocular involvement and the involvement of the mucous membranes of the mouth and genital, like genital ulcers and aftas, which we didn't have in this presentation. And for ocular involvement, again, in ankylosing, in seronegative spondyloarthritis, as in Behçet disease, we can have this uveitis, but for seronegative spondyloarthritis, this uveitis is not very severe, and mostly we have unilateral uveitis. For Behçet, mostly we have bilateral, and it's kind of severe, more severe, especially in male patients. Third, rheumatoid arthritis. Why this is not typical rheumatoid arthritis? Of course, rheumatoid arthritis can start from oligoarticular manifestations, but being negative for rheumatoid factor, not having this polyarticular manifestation, not having this typical joints, we know which joints are typical for rheumatoid arthritis, and especially having this inflammatory back pain are more typical for other diagnoses and not rheumatoid arthritis. So we have two options, ankylosing spondylitis and reactive arthritis. These are both involved in the spondyloarthritis, seronegative spondyloarthritis family, and in this presentation we have mentioned that this case is seronegative because rheumatoid factor and antinuclear antibodies are negative here, and being positive for HLA-B27 is also can be both in reactive arthritis or ankylosing spondylitis. But for reactive arthritis, we should have some connection with the previous intestinal or urogenital infection, which we didn't have in this presentation, and also this and for ankylosing spondylitis here we have the typical criteria from New York, modified New York criteria, which is the inflammatory back pain and having the limitation of motion, the limitation of mobility in spine, because for example we had Schobert test was 3 and normal Schobert should be from 4 to 5. And also for reactive arthritis, unilateral sacroiliitis is typical, and for ankylosing mostly bilateral, which we had in this presentation. So the most probable diagnosis here will be ankylosing spondylitis. So the treatment option in this case. First is nonsteroids, second oral glucocorticosteroids, third local glucocorticosteroids, and last option is sulfasalazine. Um, as we remember, the first line here, which is not involved, which is not written here, we should say that for ankylosing spondylitis, we should have regular special physical activity, which is very important, and avoiding some not normal postures. So maybe swimming will be regular swimming will be very good option in this patient, and second will be non-steroids and regular intake of non-steroids, of course, by regular checking of liver enzymes and creatinine, because these non-steroids are hepato and hepatotoxic, for example. So we should have a good monitoring of this treatment to avoid serious side effects. Second will be oral glucocorticosteroids. As you remember, especially if we don't have any systemic manifestations here, oral glucocorticosteroids are not considered effective here. So this will not be this one will not be a good option. For local glucocorticosteroids, this is also a very good option here. For example, for intra-articular injections of glucocorticosteroids, and fourth one will be sulfasalazine. As we have recurrent arthritis, because we said that this patient had also another episode of swollen knee, so sulfasalazine will be a good option. But again, remember, not for bilateral sacroiliitis, but for peripheral arthritis. So sulfasalazine is for peripheral arthritis. So, as this patient has high ESR, high CRP, and especially if this patient is positive for HLA-B27, which means that we are expecting to have more severe case. So, if this treatment does not work, we have another option, and this will be, for example, the biological treatment, for example, TNF-alpha inhibitors. Thank you for attention.